Hi, I'm Dr. DJ Heusler, and this is our module on recognition and interpretation of retinal disease. So where are we going with this module? We're going to look at proper equipment that is necessary to look at the retina, examination techniques, variants of normal, sudden acquired retinal degeneration syndrome, progressive retinal atrophy, subretinal petechiae, retinal detachment, optic neuritis, optic nerve colobomas, retinal dysplasia, optic nerve hypoplasia, and optic nerve aplasia. So the one thing that you need to remember about this subject is that this subject is not easy. There's lots of variants of normal, lots of different diseases, and so the more you practice it, like anything, the better you're going to get at it. There was a book called Outliers by Malcolm Gladwell that discussed that his theory was there was a minimum of 10,000 hours in a subject to be considered an expert, which basically just means in veterinary medicine that repetition is necessary and keep doing it until you get good at it. So a direct ophthalmoscope is one instrument that is used to evaluate the fundus of a patient. It has a poor view of the retina, about a 5-degree field of view of the retina. It's good for optic nerve evaluation. There's a slit beam that you can use to detect aqueous flare, and there's a cobalt light to detect fluorescein stain uptake. A better view of the retina compared to a direct ophthalmoscope is the panoptic. This provides a 25-degree field of view. There's a better working distance from the patient as compared to the direct ophthalmoscope. Indirect ophthalmoscopy provides the best view of the retina by far. Lenses can be purchased on Amazon around $100 for a 20 diopter lens or through various veterinary companies. The view of the retina is far superior compared to a direct ophthalmoscope. A Finoff transilluminator is a halogen focal light source. It is typically used to evaluate pupillary light reflexes. However, it's a light source for indirect ophthalmoscopy. Here you can see this picture, myself performing indirect ophthalmoscopy. And what you want to do is you want to have your light right around your temple, pointed at your lens, and your lens and your light should be about an arm's distance away to get an optimal field of view. So when you receive a patient at your practice and you want to perform an eye exam, first examine the pupillary light reflexes. Are they direct? Are they consensual? Second, you want to dilate the pupil with tropicamide and then have the patient wait 20 minutes before performing your examination. Third, evaluate all ocular media for any opacities that may block a thorough fundus examination. Then fourth, examine the fundus. It's incredibly important to remember to dilate the pupil, otherwise your examination is going to be very limited. Remember that when you use an indirect lens, the image that you are viewing is going to be upside down and reversed. This is important to remember if you're charting lesions in your medical record so as to annotate where exactly they are. The fundus consists of a tapetum, a non-tapetum, the optic nerve, and the retina. The canine and feline eye are incredibly difficult to evaluate due to the number of normal variants. So as you can see through these photos, each one of these is a normal variant. Some of them have large optic nerves, some of them have small optic nerves, some of them have yellow tapetum, some of them have orange tapetum, some of them don't have a tapetum. So it's important to continue to look at all of your patients so that you can understand that each one can be a variant of normal so that you can identify something that is abnormal. So when we look at the canine tapetum, these are all normal variants. They can be yellow, they can be orange. In puppies, they can be blue, they can be more granular looking. So again, keep looking over and over and over again. The feline fundus has much less variation than the canine fundus. The optic nerve head is poorly myelinated. There's a much broader tapetum. The non-tapetum can be pigmented or poorly pigmented. And these are all normal variants with these photos, but there's less of a range in cats than there is in dogs. The canine non-tapetum also has a variety of normal variants. It's not as wide range as the tapetum, but the non-tapetum can also have different variants of normal. Regarding the canine optic nerve, these are all forms of normal variants. Optic nerves can vary in location, size, degree of myelination, and shape. Some of these shapes and sizes can be related to breed. Golden Retrievers tend to have a very large optic nerve that is more triangular. Smaller dogs, such as Chihuahuas and Shih Tzus, typically have a smaller, more round optic nerve. So these can be located within the tapetum or the non-tapetum. They can be round, they can be more triangular, and so it's important to evaluate all of these optic nerves for variants of normal as well. In consideration of the tapetum, it's important to recognize when it comes to abnormals, is the tapetum normal? Is it hyperreflective, or is it hyporeflective? If it's hyperreflective, it typically means that the tapetum is more thin, such as this first picture. A thin tapetum can indicate retinal degeneration due to glaucoma or a previous retinal detachment or inherited progressive retinal atrophy. Hyporeflective indicates that cells were added underneath the tapetum. This can indicate blood or fluid. So in the second picture, you can see that blood is located underneath the tapetum, which is making the retina hyporeflective. Some common canine abnormalities that we see in the fundus is, this first picture shows a retinal detachment. If you're looking at this photo, this is right around the 9 to 10 o'clock position. There's a little shadow, and that's a focal retinal detachment in a patient. This next picture shows diffuse retinal vessel attenuation with progressive retinal atrophy, as well as tapetal hyperreflectivity. This picture here shows chorioretinal scarring of the tapetum. You can see there's focal areas of tapetal hyperreflectivity. This picture here shows a retinal detachment at the bottom of the photo. And then this photo here, you can see a retinal detachment at the bottom of the photo with subretinal infiltrate. And at the top of the photo, the dorsal aspect, you can see subretinal petechia. This photo here shows diffuse retinal degeneration. There's tapetal hyperreflectivity and vascular attenuation. Here are some more common canine fundus abnormalities. In this first picture, there's a retinal detachment at the ventral aspect of the photo. Secondly is retinal detachment as well. This third one shows glaucoma. There's a choroidal infarct to the left of the optic nerve and tapetal hyperreflectivity. In this picture is severe optic nerve cupping, which was caused by glaucoma. In this picture is diffuse retinal detachment, and you can see the retina billowing forward in this eye. And in this picture, there is peripapillary fluid consistent with optic neuritis. So let's talk about some specific diseases. We'll start with sudden acquired retinal degeneration syndrome. This typically affects middle-aged dogs, about 7 to 9 years old. The owners presenting complaints for their dog include dilated pupils, and they're blind and typically acutely blind. They lost vision within a week. They're frequently polyuric, polydipsic, and polyphagic, and the cause of sudden acquired retinal degeneration syndrome is completely unknown. Unfortunately, when we look at these patients, there's minimal retinal abnormalities. There's a patchy tapetal hyperreflectivity that is sometimes seen, retinal vascular, arteriolar, or box scarring that we will see. There's the definitive diagnosis is through an electroretinogram or ERG, and this helps to separate retinal disease from optic nerve disease or CNS disease. And unfortunately, at this time, there's no treatments. So here are two different tracings of an electroretinogram. In a normal patient is the first picture. This is a normal trace that we see in a dog that can see well with normal retinal function. In the second trace, we see a flat line, and this indicates that the retina is no longer functioning or processing vision. Another disease that we see commonly regarding the retina in dogs is progressive retinal atrophy. This is a progressive vision loss of variable age, typically 6 years old or older. Typically starts with night blindness first and then day blindness. Cataract formation typically comes later. As the retina starts to die, it releases dialdehydes into the vitreous, which come forward in the eye and then contact the back of the lens. And this creates the cataracts. These patients have an increased risk of glaucoma due to lens-induced uveitis from the cataract as well as the retinal degeneration. So it's important to monitor intraocular pressures in these patients every 4 to 6 months. In these photos of a patient with progressive retinal atrophy, in this first photo, this is a cataract with a fair amount of cortical vacuoles in the back of the lens. And we see this quite often in cases with progressive retinal atrophy. On this second picture here, this is a dog with diffuse tapetal hyperreflectivity, vascular attenuation, and optic nerve pallor. And in the third picture, there's diffuse tapetal hyperreflectivity, vascular attenuation, and optic nerve pallor, all consistent with progressive retinal atrophy. Clinical abnormalities that we see with progressive retinal atrophy include tapetal hyperreflectivity, vascular attenuation, optic nerve pallor, and then plus or minus cataracts. We see subretinal petechiae quite commonly in dogs of any age. Causes are systemic hypertension, thrombocytopenia, coagulopathy, and occasionally idiopathic, of which I seem to see more commonly in golden retrievers than other breeds. In this photo here, this dog has a subretinal petechia located at about the 11 o'clock position in relation to the optic nerve. Subretinal petechia can take months to resolve even when the underlying cause is corrected. So in this case here, in this first photo, this is where blood is accumulated underneath the retina and around the optic nerve, and this was due to systemic hypertension. In this second photo is a patient that has subretinal petechia surrounding the optic nerve, and in this third photo, the subretinal petechia are located at about 3 o'clock position out to the tapetal and non-tapetal border, and this was caused by underlying tick-borne disease. Feline retinal detachment are quite common. We see these, you can see this first photo, you can see the retina through the pupillary margin. And these other two photos are retinal photos where there are diffuse and complete retinal detachments. With feline retinal detachments, presenting clinical signs typically include dilated pupils and acute blindness. The average age of these patients is typically 10 years old and older. In cases of retinal detachment, posterior segment blood, or acute blindness in cats, a blood pressure is always indicated. Common causes of feline retinal detachment include renal insufficiency, hyperthyroidism, endocrine disease, and idiopathic or primary. Treatment typically consists of amlodipine, 2.5 milligrams, a quarter tablet orally once a day until recheck. There's some other thoughts to be able to use: enalapril, benazepril, methimazole, telmisartan, and those are up to each clinician's comfort level. These are some photos that are seen in the previous patient 1 week after treatment with amlodipine. This patient had a normal CBC and profile, and blood pressure had returned to 125 millimeters of mercury. In this first photo, this eye shows a reattached retina. In the second photo, the retina is still detached but is showing some improvement. With canine retinal detachments, common causes include hypertension, neoplasia, subretinal infiltrate, vitreoretinal dysplasia, hypermature cataracts, and post-phacoemulsification. Another disease that we see commonly is optic neuritis in dogs. Presentation is typically acute vision loss with dilated pupils. Clinical abnormalities include papilledema, swollen optic disc, loss of physiologic cup, plus or minus optic disc hemorrhages. In these photos here, you can see that this patient has papilledema and a swollen optic disc. This patient was acutely blind and was diagnosed with optic neuritis. There are quite a few causes of optic neuritis in canine patients, which can be quite frustrating. Some of these causes include intracranial neoplasia, optic nerve neoplasia, distemper, tick-borne encephalitis, blastomycosis, histoplasmosis, cryptococcosis, ehrlichiosis, toxoplasmosis, idiopathic vitamin A deficiency, orbital neoplasia, necrotizing meningoencephalitis, and granulomatous meningoencephalitis. Diagnosis of optic neuritis is typically made on clinical presentation. Etiology can be based on cerebrospinal fluid analysis plus or minus an MRI. Treatment typically consists of steroids as well as treating the underlying cause. Also utilizing doxycycline and other immunosuppressants can be utilized as well. Unfortunately, the prognosis in these cases is poor. Optic nerve colobomas are congenital malformations of the optic nerve head and peripapillary retina that enlarge or distort the optic nerve circumference. They appear as though they have a deep hole or excavation within the nerve head. So this variety of photos here shows various optic nerve colobomas that are seen in canine patients. With optic nerve colobomas, the visual field disturbance is unknown and likely variable. It's difficult to determine in animals due to our rudimentary evaluation of vision in animals. It can be associated with retinal detachments, and this is one of the abnormalities that is seen with collie eye anomaly. So what about puppies? Well, the tapetum continues to develop about 4 months postnatally. A blue tapetum is normal for the first 4 months in the dog as the animal matures. So if you are examining puppies, which we all do, and you look at their retinas and the tapetum comes out blue, give them at least until 4 months before you see that color to change. Retinal dysplasia is linear folding of the sensory retina and formation of rosettes composed of variable numbers of neuronal retinal layers around a central lumen. Potential causes include viral infections, vitamin A deficiencies, X-ray irradiation, certain drugs, and intrauterine trauma, as well as hereditary. They may be unilateral or bilateral, and there's 3 types: focal or multifocal retinal dysplasia, seen as areas of reduced tapetal reflectivity. Green dots or linear streaks are commonly seen. Typically occurs dorsal to the optic disc and around dorsal retinal vessels. This does not seem to affect vision for these patients. These 3 photos are patients with retinal dysplasia. All of them have linear streaking throughout the tapetum that is identified as retinal folding. The third type of retinal dysplasia is geographic retinal dysplasia, which can be unilateral or bilateral. There's a horseshoe-shaped area, most often seen in the central tapetal fundus. There's a gray or black area that encircles the area, and the central aspect may be elevated. And this type of retinal dysplasia can cause visual impairment. A complete retinal dysplasia with detachment is also possible. The retina is floating in the vitreous and attached at the optic nerve head. A leukocoria is sometimes seen, and wandering or rotary nystagmus is seen, and this causes complete blindness in these patients. With multifocal retinal dysplasia, most lesions do not change with time. Sometimes they may become less obvious, and sometimes they may become more demarcated. With geographic retinal dysplasia, the lesion never disappears, becomes more demarcated with time, and with complete retinal dysplasia with detachment, complications such as secondary cataract, glaucoma, and hyphema may develop. With hereditary spontaneous retinal dysplasia, we see this in breeds such as the Bedlington Terrier, the Sealyham Terrier, Yorkshire Terrier, Rottweiler, English Springer Spaniel, American Cocker Spaniel, Labrador Retriever, and Golden Retriever. With geographic retinal dysplasia, we see that with King Charles Spaniels as well as Golden Retrievers. And Labrador Retrievers can develop all 3 types of retinal dysplasia. Optic nerve hypoplasia is another congenital disease that we see. Optic nerves that are less than 2 standard deviations from the mean diameter are considered statistically abnormal. And if the number of axons is so low that visual and pupillary light reflex deficits are present, this is optic nerve hypoplasia. With optic nerve hypoplasia, the afferent reflex is typically abnormal, whereas the efferent reflex is normal. The pupil is generally partially dilated, electroretinogram readings will be normal, and heritability has been reported as recessive, dominant, and undefined in miniature and toy poodles. With optic nerve aplasia, this is a complete absence of retinal ganglion cells in the optic nerve. No retinal vessels are present, and this is seen in the Beagle breed, Irish Wolfhounds, and the Shih Tzus. Pseudopapilledema isn't really a disease, but it is something that we see as a normal variant. It's an anonymous elevation of the optic nerve head. This may resemble optic neuritis, tumors, or elevated intracranial pressure. Excessive myelination beyond anterior lamina curvosa. And this is seen in the Golden Retrievers, Labrador Retrievers, curly-coated retrievers, miniature poodles, English Springer Spaniels, and German Shepherds. Nothing needs to be done with this condition. So that completes our module on retinal disease. Thank you so much for watching.